This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the University of Lyon and the Timisoara Neuroscience Research Center, recently published in Acta Neurochirurgica in 2026. The paper is titled, How I Do It, Microvascular Decompression for Vago-Glossopharyngeal Neuralgia.
This is a timely piece, Ilara. While we talk a lot about trigeminal neuralgia, glossopharyngeal neuralgia, or GN, is actually quite rare. The authors note it represents only about 0.2 to 1.3% of facial pain cases, whereas trigeminal neuralgia accounts for the vast majority, nearly 80 to 90%.
Exactly. And because primary classical GN arises from a neurovascular conflict, microvascular decompression, or MVD, offers the most durable treatment when medication fails. The paper specifically highlights that while radiofrequency lesioning or stereotactic radiosurgery are alternatives, they generally yield less robust long-term outcomes compared to MVD.
Let's dive into the anatomy described in the study. For our residents listening, the authors emphasize the intimate arrangement of the lower cranial nerves. Dr. Ilara, how do they describe the rootlet configuration?
They specify that the glossopharyngeal rootlets, CN9, usually number 1 to 4 and emerge from the rostral portion of the post-olivary sulcus. The vagus nerve, CN10, arises immediately caudal to that, with a longer series of 8 to 10 rootlets along the same sulcus. Because they both converge toward the jugular foramen to enter the pars nervosa, vascular compression often involves both nerves simultaneously. This is why the authors refer to it as Vago-Glossopharyngeal Neuralgia, or VGN.
Right, and the culprits are usually the posterior inferior cerebellar artery, PICA, often in association with a compressive megalodilico-vertebrobasilar artery. Now, before we even get to the OR, the preoperative planning section in this paper is very specific. What's the imaging gold standard here?
They insist on high-resolution MRI with T2-weighted CISS, Fiesta, or drive sequences. They also recommend T1 post-gadolinium to depict veins and 3D time-of-flight angiography to characterize the arteries. They even mention fusion imaging to enhance the detection of the conflict.
And don't forget the clinical workup. They mention 2 essential consultations. First, an ENT consult to rule out local pathology that might mimic GN. Second, because GN can be associated with syncopal episodes, all patients must undergo a systematic cardiac evaluation. That's a critical safety point.
Moving into the OR, let's talk anesthesia and positioning. The authors prefer TIVA, total intravenous anesthesia, using propofol and remifentanil. They emphasize limiting neuromuscular blockade to the induction phase only. Why is that, Dr. Aris?
It's for the intraoperative monitoring of the lower cranial nerves. You need to see those EMG responses. They also suggest brainstem auditory evoked potentials, especially during the surgical learning curve. For positioning, the paper describes a lateral decubitus position with the patient slightly rotated backwards so the shoulder falls away from the surgeon.
I found the head positioning details very precise. They use a 3-pin head holder, 1 pin above the ipsilateral eyebrow and 2 on the contralateral occipital bone. The head is slightly flexed, keeping the chin about 2 finger breadths from the sternum to prevent venous obstruction. They also emphasize a slight lateral flexion to prevent the shoulder from obstructing the surgical corridor.
It's all about the corridor. They plan a retroauricular incision, inferior to the asterenial region, extending toward the mastoid tip. This sets up a keyhole retrosigmoid craniectomy at the level of the mastoid tip.
One technical detail they mention is the occipital artery and the great occipital nerve. If the artery is encountered, it's ligated, but they prefer mobilizing the great occipital nerve rather than sectioning it to avoid postoperative neuropathic pain.
Smart. Now, once the bone is off, about a 3-centimeter length of the sigmoid sinus edge is exposed, they open the dura in a curvilinear fashion. Dr. Ilara, walk us through the actual approach to the nerves.
This is the infrafloccular approach through the cistern magna. After opening the dura, they release CSF from the cistern magna to allow the cerebellum to relax. Then a self-retaining retractor, they use narrow sagitta blades, is placed on the lateral surface of the cerebellum tonsil. This creates a corridor beneath the flocculus toward the retroolivary sulcus.
This allows them to see the lateral medulla and the root entry zone of the lower cranial nerves. Once the conflict is identified, again, usually PICA or the vertebral artery, how do they handle the vessel?
They use bayonet scissors for sharp dissection of the arachnoid membranes and fine bipolar forceps for hemostasis. A dissector probe is used to mobilize the vascular loops from the 9th and 10th rootlets. For the actual decompression, they use polytetrafluoroethylene, or PTFE Teflon. It can be shredded or knitted depending on the situation. They mention polyester Dacron is more rarely used.
The goal is vessel transposition or Teflon interposition to relieve that conflict. One safety step they mentioned during the exposure is that if mastoid cells are opened, they must be occluded to prevent CSF leaks.
It's a very systematic how I do it guide. The authors conclude that by using this retromastoid retrosigmoid infrafloccular approach, you can safely and effectively treat drug-refractory cases.
It's a rare procedure, but for the patient suffering from the intense lancinating pain of glossopharyngeal neuralgia, it's life-changing.
Absolutely. That covers the key highlights of the Brinzu, San, and Sindhu paper from 2026. For our listeners, the step-by-step technique and the anatomical diagrams in the full text are highly recommended for your next VGN case.
Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.